I'd like to thank the National Kidney Foundation for having me here today to talk to you about dialysis modalities. I'm sure there are a lot of you here who are chronic kidney disease patients, a lot of people who have been on dialysis, and of course we saw transplant recipients here as well. We've heard Dr. Swanson, we're going to hear Dr. Leeser. They do their own thing, they do fancy stuff. I'm the meat and potatoes guy. My job is to make sure everybody stays healthy, has a good life, and gets to where they want you to be. So I was asked to come and talk about the different modalities or how we deal with patients when they have kidney failure, what their options are. So I'll try to make this interesting. Please feel free to stop me if you have any questions. You can save it for the end. You can ask me as we go along. So just to give a little background, what do our kidneys do? So the first function of the kidney is really to clean. They filter blood, and they get rid of waste and water. The second thing that they do is they balance. And what do I mean by balance? Our body is a closed box. What goes in must come out. There's very little that's retained. The kidneys play a major role in maintaining this balance. Fluids, electrolytes, all the little elements in our body, all balanced, kept in balance by the kidneys. And they also regulate, which is their third function. And what does this mean? They make a lot of hormones, hormones that help control blood pressure, hormones that help with bone metabolism through calcium, phosphorus, and vitamin D processes, and of course, the hormone that helps with red blood cell production as well. So this is the major function of the kidney. So what is chronic kidney disease then? It's the slow, progressive loss of renal function. This is not reversible. It happens over months to years and eventually progresses to a stage where you will need renal replacement therapy or some form of intervention from us to keep you alive. Let's talk about some facts about chronic kidney disease. It's rampant. 26 million Americans have chronic kidney disease, and there are a lot more that don't know they have it. It's a silent condition. You heard from Carrie there that she didn't feel bad. She felt like something was poisoning her, like she had the flu that didn't want to go away. It's silent. There's no way that you're going to know it unless you have blood tests done, unless your blood pressure is exceedingly high. It's not going to really bother you. It doesn't hurt. The goal is to identify kidney disease early and slow its progression. That's the main goal here. Diabetes, high blood pressure, and of course a family history of kidney disease are the major causes of kidney disease. Diabetes and hypertension, the number 1 and 2 causes of kidney disease worldwide. Now heart disease, and you heard from her too about this, is the major cause of death in people with chronic kidney disease. It's not the dialysis itself that kills people, it's the fact that they get heart disease. Why? Because when you have end-stage renal disease, the processes in your body get accelerated. The blood vessels harden faster. That causes heart disease. So how do we measure kidney function? We do simple tests. We do blood tests. We look at creatinine. We measure something called the GFR. And we do simple urine tests looking for protein. If you have protein in your urine, you likely have chronic kidney disease if it's persistent. Some people are more prone to having chronic kidney disease and progressing to dialysis. African Americans, Hispanics, elderly patients, they're more prone to getting chronic kidney disease and then moving on to dialysis. African Americans are 3 times more prone to developing end-stage renal disease. So this chart basically shows you the stages of chronic kidney disease. This is based on how well your kidneys work or don't work, of course. We're concerned with all the stages, of course, the goal being we want to slow the progression of kidney disease. But for my talk specifically, what I'd like to focus on is stage 4 and stage 5. because stage 4 is truly where we start the modality discussions. And stage 5 is when we actually proceed and go to dialysis and take care of people there. So let's go ahead with the next slide. So what happens when kidneys fail, really? I told you the job of the kidneys is to clean, to balance, and to regulate. So if you don't clean, you get waste and water build up. No, one back, please, I think. Yeah. Okay, sorry. So let's go ahead, one more, sorry. So when kidneys fail, we need treatment to basically clean, balance, and regulate whatever the kidney was doing. The cleaning, of course, is needed to get waste out of the body. The balancing, as I said, to maintain the electrolytes and allow the other body cells to function appropriately. And then the regulatory part involves us treating you with other medications to keep bone health, blood production intact. So what are the options then when kidneys fail? There's dialysis. I'm sure everybody has heard the word dialysis here. And probably everybody knows that there are more than one kind of dialysis. There's dialysis that we call peritoneal. It's done using an abdominal cavity and a membrane in the abdominal cavity that we'll go through. And then there's hemodialysis, which is the more common type of dialysis. Peritoneal dialysis is still not very common in America, but in the Eastern world, it is the primary modality. In Europe, it's more prevalent than hemodialysis. Of course, we have renal transplantation that Dr. Lisa will talk to you about. We've heard a lot from Dr. Swanson about what's to come in the future, too. Very exciting. And then I put the word no treatment there because sometimes that is a relevant option as well. People have choices. People can make choices, and we'll go over those. So let's talk a little bit about what happens when you do dialysis. So this is a mechanical process. Whichever kind of dialysis we think about, this is a mechanical process. We use a solution called a dialysate, and we have a filtering membrane. Different kind of filtering membranes that we'll see. And the goal is to remove waste and water and to maintain the body's internal environment intact so that it allows for survival. Let's go ahead. So let's talk first about peritoneal dialysis. Anybody familiar with peritoneal dialysis? Anybody done peritoneal dialysis? Good. Excellent. We'll get perspectives from people later because this is important. So what happens in peritoneal dialysis? We use a dialysate. It's nothing but a solution that has some good stuff that your body doesn't make anymore. And we have the membrane. Like I said, in peritoneal dialysis, we have a big belly cavity here that is lined by a membrane called the peritoneal membrane. This membrane has a lot of blood vessels on it. That's where the blood comes from. That's what allows the exchange. The membrane itself has small little pores that facilitate the movement of fluid and waste products into and out of the dialysate and blood. So we can go ahead. What happens here? We need a little tube called the PD catheter to be placed either in the belly or in the chest to allow for this process to occur. So then what happens? We have the dialysate. We fill the belly cavity with the solution called the dialysate. We let it be there for a certain number of hours. There is exchange of waste product and fluid between the fluid and the blood vessels or the capillaries. After a certain amount of time, the fluid in the cavity now is considered dirty and has to be emptied out. We empty it out and we go back in and fill again. So the whole process of filling, keeping the fluid in for X number of hours, and then draining it out is called an exchange. That's one exchange. So let's go ahead. So I'm sorry, the slide is a little in off order. The first step is the fill. Then comes the dwell, where you have the fluid in the belly cavity. and then comes the drain. Now, how long does an exchange take? It sounds like a rather complicated process, but it takes 10 minutes to fill. We dwell in for anywhere between 4 and 6 hours, and the drain takes about 10 to 20 minutes. The whole process of the fill and drain totally takes 30 minutes. When you have the fluid in your belly, you're free. You can unhook, you can go about doing what you want, you don't have to be hooked up to anything. So in a day, when you do an exchange, it takes 30 minutes to do one exchange. And we'll go through a little more detail. We got two types of these things too in peritoneal dialysis itself. There's one that's called CAPD, and as the name says, it's continuous. It's ambulatory. You can walk around, you can do what you need to do, and it does your dialysis, or PD. And there's the other kind called the continuous cycling peritoneal dialysis. Let's look at these. So in CAPD, typically a patient does 3 to 5 exchanges in a 24-hour period. You spend 2 hours of your day doing your dialysis, but it gets you 24 hours of cleaning. It takes about 30 minutes, like I said, to do an exchange. And an exchange really doesn't need to be done in a sterile environment. Mr. Joe there is sitting on his boat and doing his exchange. As long as you have a clean table, you have gloves, and you can wash your hands, we're good. We also wear a mask, by the way, very important. Let's not forget that. And that's basically what it takes to do PD. You can do it anywhere. It doesn't compromise on your life, keeps you more mobile. People can work. Let's go ahead to the cycler. This machine is called a cycler. So what this does is it helps you do the PD. You hook up to this at night. It's programmed. So you put in, the nurse helps you program it, you learn to program it, you put in the bags you need, and then you go to bed. And the machine does everything for you while you're sleeping. You wake up in the morning, you unhook, you're free. Some people may need one exchange during the day, but a lot of people just do it at night. Okay, this is the cycler. So let's look at some of the advantages of PD. I call this a superior therapy, and the reasons for this. Why? Because I said we do dialysis 24 hours a day. It takes 2 hours of time every day to do this, but it's continuous. What does our kidney do? Does the kidney take a break? No, it works 24/7. This dialysis works 24/7 too. Are you going to feel better with this? Absolutely. It replicates your kidney function better. So not only does it keep the waste and water in balance, your energy levels are better, you're more functional. Now, if the cleansing is going on more often, you could probably eat and drink better too, a lot of which you can't do on the hemo side. There's no needles, there's no blood involved here like you do with hemodialysis. You're mobile. People go to work with this. I have a lot of patients that stay working. They talk to their people at work. They have a little room set up. They do one exchange during their lunch break. It takes 30 minutes. Come back home, do the rest of your dialysis. The goal is to keep people working. It's important because if you're going to sit and worry about kidney disease and what it's going to do to you, probably going to make you depressed. So if you can keep working, take your mind off, and proceed with life, this is a good option for you. And this is what I like about it too. The patients are in charge of their health. It's a partnership here. They have to do some for themselves to make this work well. So it gives you control. So let's switch gears a little bit. That's PD. If anybody has questions about PD, I'll be happy to answer them. We'll move on to hemodialysis. Everybody's heard the word hemodialysis. It's the most commonly used kind of dialysis. And basically, again, we have a dialysate and we have a filtering membrane. Here, the filtering membrane is the artificial kidney. It's composed, it's a little plastic tube that is made up of thousands of capillaries. It's got about 20,000 capillaries in it. And what typically happens, you can go ahead to the next slide, is blood under a certain amount of pressure flows in one direction through this little artificial kidney, and in the other direction we run dialysate. We allow the exchange to take place. A typical treatment is anywhere between 3.5 to 4 hours. It depends on the patient's size. It depends on their access. So it's typically between 3.5 to 4 hours. And in this process too, we remove waste and water, but we're doing it in a very short period of time, 3.5 to 4 hours. And then the clean blood gets returned to your body. A little more schematic version of it, you got to get blood out of the body, pass it through the machine. Of course, there's a pump there that generates a certain amount of pressure that is required. We add a little bit of what we call an anticoagulant so that the blood doesn't clot. And it goes through the machine that has the dialyzer or the artificial kidney there. Cleaning takes place. 3 hours later, 4 hours later, the clean blood gets returned to your body. Now, the clean blood is going back, but our body has 5 liters of blood in it. And at any given time here, we process about 300 to 400 ml. Okay, so we clean a lot of blood at the 3 hours, but in small parts. Now, in order to do hemodialysis, this is important to know. We got to get blood out of the body and put it back into the body after it's been cleaned. So we use what we call a vascular access here. The one you see on top is called a catheter. Doesn't look good at all, right? It's a little plastic tube, pretty big one, sits in one of the big vessels in your neck. Breaks the skin barrier and goes in. It's used only if people need emergency dialysis. If I'm following somebody for a long time, when I start with that, I lost. I didn't do my job right. So the catheters do get infected. You can't shower when you have a catheter. And then it's sitting in a big blood vessel in your neck. It causes the blood vessel to scar, which then does not allow us to put a graft or a fistula into your hand. The bottom picture shows you a graft and a fistula. A fistula is when we connect your artery to your vein, and we create a circuit essentially to get blood out, cleaned, and put back into your body. A graft is where we use a piece of synthetic material to make this connection. Now, who decides who gets what? It depends on what quality veins you have. We do a study to look at the veins, and then the surgeon decides which one will be placed. The goal is to have an AV access. The fistula is the best. The graft is the second best. Catheter is the worst. So all of you guys who may be in different stages of kidney disease, please realize that the fistula is the best option to have. I tell my patients, even if we're not there at stage 4, when we start planning, as you get to advanced stage 4, we want to do this. We obviously review modalities. I personally would encourage people to do PD, but if somebody wants to choose hemo, fistula is what we want to have placed. Is it good to have money in the bank, guys? Everybody likes money in the bank, right? This is what it looks like, Put it in. We don't need to use it if we don't have to, but it's there. Should a rainy day come, we can go ahead and use it, okay? Think about it in that fashion. It's money in the bank. It ain't going to hurt you just being there, but it's ready to go. Okay. Going back to hemodialysis, 3 times a week, 3 to 4 hours per treatment, you got needles. You have to deal with the needles, and despite the fact that I say the fistula and the graft is the best, you still have the needles, okay? It's usually done in a dialysis center, but nowadays we're getting better at it. We got home hemodialysis coming, okay? Or it exists, and I'm going to talk to you a little bit about that. It doesn't exist everywhere. In some areas, it's more freely available than in others. But let's talk a little bit about the different variants. Well, actually, let's talk about the pitfalls of conventional in-center dialysis first. So you're a dialysis patient at a center. You have a fixed time. You got to show up either on a Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday at 6:30 a.m. or 10:30 a.m. There's no flexibility really. You come late, you probably lose a little treatment time because there's a shift coming right behind you, and they're not going to compromise the other person's treatment. it snows like it did last week, people can't get in. You can't get your dialysis. It's a problem. You got a fixed schedule that you got to deal with. We do it only 3 times a week. How long does our kidney work? 24/7, right? In 3 times a week, 9 to 12 hours, I'm trying to replicate what the kidney does. So when you come into a dialysis treatment, what happens? You're full of waste and water. And then in 3 hours, I remove all that waste and water. Some people don't handle that very well. Your heart doesn't handle that very well. Your blood pressure can drop. A lot of stuff that happens on the hemo side. And again, because this is a rapid, fast process, replacing kidney function in a short period of time. Now, after you get cleaned, can you go home and eat what you want and drink what you want? No, not really. Because the more you eat and drink, the more I got to work on your next treatment to pull it off. If you pull off too much, you're going to feel really bad. So we always advise you to watch your fluids. And I'm sure you guys have met a dietitian over there. There's restrictions and a whole lot of stuff there. We spoke about the schedule and its flexibility. People are not very involved with their care on hemo. Some are, some aren't. Some just treat it as, well, I got to be here, I got to do my treatment and move on. So there's limited involvement. And of course, we got the needle issue, which doesn't change. So there are some variations of hemodialysis now that are available. We can do this at home. They set up a machine. They have a little small machine that gets set up at your house. Of course, the machine has to have water treatment within it. You still have to have access. And the beauty of it is you're still at home. It's more convenient. You don't have to get to the 6:30 shift. Let's go ahead, one slide, please. The standard home hemodialysis is done 3 times a week, sometimes a little more often. You do 3 to 4 hours per session. It's like doing hemo at a center, except that instead of the center, you're doing it in your house. You have the convenience of home. Your schedule can vary. You can say, I'll do it this afternoon at 2 o'clock because I had to go out somewhere in the morning. You got control. People like to have control. You need a partner, however. This kind of dialysis wants somebody at home just in case something goes wrong with the needle in your arm or the machine or something that you can't troubleshoot right away. It requires a partner. Now, studies show the survival with this kind of dialysis, just from center to home, is actually much better. It's actually much better. I guess we know our body better at times. Then we got a little better version of this. We got daily home hemodialysis, or we got dialysis at home that we can do at night. More is better? Yes, in a way more is better. It's more continuous. We're replacing your kidney function, or we're replicating your kidney function a little bit better. This kind of therapy is done 5 to 6 times per week, about 2.5 to 4 hours, except if you do the nocturnal kind, then you hook up to the machine and you run it longer while you sleep. And it's got the convenience of being home. You can eat and drink better because you're doing this every day. It's a more continuous process. Now, in certain states, this does not require a trained partner. I guess the notion for this is you just do it so many times that you're considered to be good enough to do this. And look at that. The survival of this is even better than doing it 3 times a week at home. And compared to in-center, this is 3 times better to survive. So yes, it makes a difference about doing this daily at home. Now, you could go to a center at night, and these centers do exist where they will hook you up to dialysis. You sleep over there, it does your dialysis, you get up in the morning and go your merry way. And this is also done about 3-4 times per week, but these sessions are 8 hours. The difference in this is the removal of waste and water is more gentle. The damage it does to your body by the rapid removal is not as much. Your heart tolerates this better than it would tolerate a conventional dialysis treatment of 3-4 hours. And again, survival with this is much better. So here's my chart that I found that basically goes over the different modalities versus in-center. Just one thing I want to highlight. In-center, the only advantage is it's available in all states. Really has no other advantage compared to the home modalities at all. The home modalities, as this list talks about, helps you do a whole lot better. Let's switch gears a little. We talked about dialysis. We got Dr. Leisha coming next, but I just want to throw this there as the modality. Transplant, no doubt, the best option you could possibly have. Quality of life is much better. Why? There's no dialysis. Okay, that's single most important reason. There's no dialysis. Survival is better because this kidney actually does what a kidney is supposed to do. And what happens when you have end-stage renal disease is that environment affects all other organs. Now with the new kidney, you've changed the environment completely. The other organs do better too. It does require being on anti-rejection medications, and we have to closely watch you for side effects of those medications. But that is a small price to pay for making you feel much, much, much better. And just want to touch a little bit on the types of transplant. We got two different types. A living donor could be a relative of yours, or could be an unrelated person. And then we got the deceased donor where somebody has passed and we retrieve a kidney from them. Living donor transplant, a blood relative, a family member, or a friend. We've heard the story. This is a planned surgery. We heard that story too. You know, we had a date. Now this works great if you're not on dialysis yet too. Imagine never having to see dialysis. You have a donor. We planned the surgery. Before you hit the dialysis machine, somebody gives you a kidney, you get a transplant. Never deal with dialysis. Fantastic. She mentioned that to you already. The donor is screened from head to toe. We don't take kidneys out of people who cannot donate or not eligible to donate. They go through more rigorous testing than the recipients do. Because what we don't want to happen is down the road, they end up in trouble. So if you ever have friends and family who want to donate, people have the fear of donation, but actually we're screened extensively. And the long-term survival of this kind of kidney is the best, the living donated kidney. The deceased donor transplant, if you don't have a donor, you get on a list. The average time in the state of Maryland, about 3 to 5 years on the list. When you're on a list, every 2 years you got to keep up with all your tests to make sure that you still stay active. Things change in 2 years on dialysis. A lot of things can happen. The graft outcome is not as great as a living donor. Again, we heard otherwise. You know, there are instances clearly where these kidneys do very well too. Patient survival beats dialysis, no question. And no treatment. It doesn't sound good, right? I'm telling you, without your kidneys, your body can't survive. But then I'm telling you, no treatment is an option. There are a lot of people where no treatment is not a bad option. These are people who have advanced issues. You got such a bad heart that, you know, while I can do dialysis, if it's even feasible with the bad heart, I don't change anything that, you know, will make your cardiac function better per se. If you have conditions where you have no quality of life, you can't get around, you can't enjoy things, those people may choose, you know, I don't want it. I have a lot of elderly people who, when we start talking about this, say, Doc, God gave me a good life. I'm 85 years old. Thank you for all your input. Here's my take to you. When I reach this stage, keep me comfortable, friend. Good conversation to have because now I know their wishes. You know, I'm not standing over them in a hospital and saying, okay, you know, you do this or you're going to die. I know their wishes. We've been through this. We've discussed this. They're happy. knowing that they don't want treatment. They make the choice. And of course, like I said, it's personal choice in some cases. So what do I recommend? Be engaged, stay positive. This is about you. This is about knowing your risk factors. This is about you helping me take control of those risk factors. Education is the most important thing. We want to sit down with you. We want to talk to you. We want to educate you about your options. There are options. You've seen the options. Of course, I don't provide the sexiest of options, transplant, etc. The other people do that, but transplant is the best. But in order to get the transplant, I still got to keep you going, and I got to keep you going good. And then I want to make sure you understand what you're getting into, what you're comfortable with, what will work best for you. So my job is to make sure you know all the options. Discuss the modalities. It's very easy. There are a lot of tools online these days. You go anywhere, you got Kidney Smart, you got Kidney School, you got the National Kidney Foundation. But I think there's a little personal touch when the physician talks to you about this. Because I tell my patients, if I were to get into this situation, I know what I'm doing. I'm going to pick doing dialysis at home. I want to be in charge. I want to work for the transplant. I want to start getting to that transplant level as soon as I can. And like I said, plan for timely access, get evaluated for a transplant in appropriate time. When your function falls below 20%, you're eligible to be evaluated for a transplant. You don't have to be on dialysis to be evaluated for a transplant. It can start sooner, you can be on the list sooner, you can pick up time sooner. And money in the bank is always a good thing with the access. Don't forget that. Okay. And lastly, is there one more?
Yeah, sorry.
This is the most important thing, guys. This is a partnership. I cannot do this without your help. So come see us, be educated, know your options, help us take care of you. Okay? I think that's it. Anybody have any questions I can answer?
I got one for
Sure.
post-transplant.
Yes, sir.
For post-transplant, care of your fistula, how often do you think you need to get that done?
Care of your fistula.
My fistula, I got a transplant, do I need to get this cleaned? How often do I gotta get my access?
You don't need to touch it.
Don't touch it.
Pray that the kidney works well. We'll keep that kidney going. The fistula, unless it, you develop a aneurysm or something that impacts it, no, it's money in the bank. Don't need it, don't touch it.
So in other words, as long as I feel a pulse in there.
Watch for that. Watch for that. Just keep that going.
Thank you.
Thank you.